Okay, this last part of upper GI that we're going to be talking about is covered in chapter 63 in your Iggy book. This part is going to be talking about malnutrition and obesity. Now, when we're talking about these types of nutritional standards, we need to talk about what is normal, what are some of the guidelines for the current population, and these have gradually changed over the years. You just need to kind of be aware of what the standards are out there. Dietary guidelines for Americans is covered in table 63-1 in your Iggy book. But guidelines basically are geared toward controlling calories, cholesterol, controlling fat intake, sodium intake, and sugars. We need to be aware there is a diagram that is put out by the Department of Agriculture that we need to use to kind of counsel our clients and our patients on what their intake should be. This is called My Plate. And it is basically just breaking down the food groups and showing you what a patient's plate should look like. When you look at what's required, half of the plate is really composed of fruits and vegetables. The other half contains your grains and proteins. Current guidelines talk about your grain intake should be really half of it should be comprised of whole grains. Then, of course, you have your proteins and your dairy off to the side there. But when we're doing looking at our standards, we have to be very aware that there are cultural considerations out there. Any dietary teaching that we do has to include cultural awareness, cultural considerations, preferences of the different cultures. So we have to assess that. What is the preference of the patient? Do they have any kind of allergies? Do they have lactose intolerance? Those kind of things that we need to be aware of, because certain cultures do have greater problems with allergies of different kinds and lactose intolerance. We have to look at the age of our patient. There are specific geriatric requirements or considerations out there, which basically talk about water intake. Our geriatric patients need to have at least 8 glasses of water a day. Fiber increases is needed in increasing amounts, as well as they also need to increase the amount of calcium, vitamins D, and vitamin B12 in their diets. On the other hand, they also need to be decreasing the amount of sodium and cholesterol that they're having in their diet. Iggy also talks about other kinds of personal preferences when you're looking at dietary intake, and among these is looking at those clients who are vegetarians. Your book talks about different kinds of vegetarians, but just be aware that if you have a patient that is a vegetarian, that is, they have decreased their consumption of meat or any meat byproducts, and there, like I said, there's all different kinds out there. People with these type of things do have nutritional imbalances. Sometimes your patient may be anemic because of that. So these patients need to have B12 incorporated into their diet in some form or fashion. They also may be low in calcium, iron, zinc, or vitamin D. So we need to counsel our patients on their intake, but be very aware that there are, issues with those specific types of diets. Now, when we're talking about nutritional assessments, we're looking at patients who may be malnourished, they may be well-nourished, or they may have problems with obesity. Keep in mind that there are many influences there that affect the nutritional status of your clients. Age certainly has a bearing. Your patient's culture, as we've talked about, your patient's socioeconomic status. Maybe they don't have the money to buy the necessary nutritional foods that they need. There may be disease processes, infection, or medications that are affecting their intake. We are doing screening assessments on patients. Every patient that's admitted to hospitals now are screened within 24 hours of admission to get to see, are they at risk for nutritional problems. If we do have questions or concerns about their nutritional status, a more in-depth assessment needs to be conducted. There is an example screening in your book on page 1337, and if you look at that, it really just is asking just some basic questions about your patient's nutritional status, attitudes toward nutrition, and then looking at some of those influences that could affect their nutrition. We're also doing physical assessment. Your book talks in great deal about anthropometric measurements. That is really your body measurements to look at your patient's height, weight, looking at their body fat, body mass index, ideal body weight, skin fold measurements, those kinds of things. And there are formulas and things like that your book talks about to determine your patient's ideal weight, to determine your patient's mass index and those kind of things. So just take a look at those. I'm not going to ask you to figure out a body mass index, because most of your organizations have got a grid there that, based on the height of the patient and the weight of the patient, it tells you what their ideal weight should be, or it tells you what their body mass index should be. And so that's why it's very important that we get a very accurate height and weight on our patients, so that we are dealing with correct values when we're looking at nutritional assessment. We need to look at our, we're assessing our patients' physical attributes also to look at their nutritional status. Hair, skin, GI tract, extremities, neurologic condition, cardiovascular conditions. All these can give us an idea about their status, and we'll talk about those in just a little bit. Labs that we're concerned with. If a patient is having problems with their nutritional value, we're going to see problems with their hematocrit, their hemoglobin. So we need to be checking those. We need to check their protein levels, iron, cholesterol. We're also concerned with lymphocyte values, because their immune system is going to be affected by nutrition. So there again, these people are going to be at risk for infection. Now, when we're talking about the malnourished patient, this is a patient who has undernutrition. Okay, your book talks about 3 forms of protein, calorie malnutrition. I'm not concerned that you're able to spout those off. I really mainly want you to know that your patient is malnourished as a result from inadequate nutrient intake. They may have an increased nutrient loss, or for some reason they have an increased nutrient requirement that they're not meeting. So what happens with long-term malnourishment is your patient starts to get some complications. They start to have muscle atrophy, and this includes both respiratory muscles and cardiac muscles. So you may see problems with gas exchange. You may see problems with cardiac output. Your patients are going to have a decreased activity tolerance. They don't have the energy to do normal daily activities. They may become lethargic. They have edema, because remember, they're malnourished. They have problems with their fluids and their electrolytes. They have problems with skin changes, dermatitis, poor wound healing, and then of course they have issues with infection. Some of your patients with eating disorders actually can result from mental type problems, such as anorexia and bulimia, and these are long-term therapies for those types of conditions. When we're looking at our risk assessment for the patient who is malnourished, or the risk for being malnourished, you see an assessment on chart 63-2 on page 1340 in Iggy, but basically it's asking questions about their appetite. Have they had weight loss? Poor fitting dentures and socioeconomic problems may be the reason that your patient is not eating. Maybe they have ADL problems. They're not able to feed themselves. Mental health issues, and maybe pain is why they're not eating. But we're also looking at, do they have chewing and swallowing issues? Maybe they don't have enough time to eat. Maybe your patient needs to be fed. Sorry, excuse the typo there. That's supposed to be fed. Maybe they need to be fed, and nobody has picked up on that need that the patient has. Sometimes your patient just needs encouragement or maybe even a reminder that they need to eat. You look at your patients with dementia who are able to feed themselves, but they just forget that they need to eat. So reminders, encouragement, a physical presence there with your patient to instruct them that they need to take a bite, those kind of things. We're looking at our physical assessment again. In the malnourished patient, we're going to look at those things that we talked about. You're going to see changes in their hair and skin, GI system. Their hair is going to be dull, lifeless. You may even see hair loss. Skin will be very dry, scaly. They will have problems with bruising. They'll have problems with rashes. In the GI system, your patient's going to have GI upset, nausea, vomiting, diarrhea. And remember, guys, these things are really coming from an alteration in their electrolytes, nutrients, proteins, some of those things that you learned about in 102, that these are the reasons. It's not necessarily the food as a whole. It's just maybe specific nutrients that they're missing is causing them to have some of these physical signs. They have problems with their mucous membranes in the mouth. The tongue may become swollen, red. Gums may bleed. Your patient will have muscle wasting, bone pain, fat loss. They may have neurological consequences such as disorientation and neuropathy. Your patient may have cardiovascular problems, congestive heart failure, arrhythmias, cardiomyopathy. So we need to be looking at these things. Our labs may show problems with anemia, decreased white blood cell count. They may have clotting problems. Again, this has to do with iron and protein, those type of things that affect these lab works. So what do we do about it? First thing that we need to do on any patient who has a nutritional issue is we need to have a dietitian consult. Okay, these are the folks, that's their specialty. That's their specialty, and they're able to consult with your patient and with you to see what is the best management style and management for these patients. Feeding schedules. Your patient who is malnourished is probably not going to be a person who's going to sit down and eat 3 big old meals a day. Maybe we need to put this person on a feeding schedule. Every 4 hours, we offer them food. Maybe small, frequent meals is going to be more in tune with what they're going to be able to tolerate. Patients that are malnourished need to be put on some type of nutritional supplement, something like Boost or Ensure. Those things are really helpful in aiding their nutritional intake. Patients are often put on or instructed to keep a food or fluid intake diary where they actually record over a 24 or 48 hour period everything that they eat and everything that they drink. Not only what it is, how much it is, and it can actually give your patient and the dietitian and you an idea of what exactly your patient is doing and eating and how can we improve that intake. Daily weights are always a must on patients who have nutritional issues, and then sometimes we put these folks on medications to augment their nutritional status. These folks need to be on multivitamins. We may need to have zinc and iron supplements as well. So we've done that kind of management, but now we actually need to get some food in them. Okay, oral intake. We've got to promote nutritional intake. Your Iggy book on 1343 has got an excellent chart that talks about how you can promote nutritional intake in your patients. Things just as simple as making sure that your patient has been to the bathroom and that they have mouth care before they eat. That they're not in excruciating pain when you serve them their meal tray. Patients are not going to eat if they're in pain. Getting your patient out of the bed and into a chair for all meals works wonders. sometimes we need to remember that the patient cannot open their packages and their milk cartons and all that stuff. So we need to make sure that that's done, that the tray is open and prepared for them to eat. Straws are open, those type of things. Sit with the patient. Encourage them to eat. If your patient cannot feed themselves, you may need to feed them. And then we need to decrease all distractions during feeding times. Don't interrupt the patient while they're eating. So try to control any kind of interruptions, such as lab tests and things like that. Schedule those accordingly, so that your patient is not disturbed when they are trying to eat. If oral intake is not enough to maintain your patient's nutritional status, there are other ways that we can get nutrition to them. One of those that you're aware of is the enteral route. This is either feeding the patient by a nasogastric tube or an enterostomal tube, such as a PEG tube or jejunostomy. Just like you learned in 102, these are tubes that are put in that we may use continuous feedings or bolus feedings for our patients. But remember, these things do carry complications. They get into problems when we do try to refeed them after they've been on tube feedings. The tube can always be displaced or put in incorrectly. That's why it's so important that we monitor tube placement, confirm placement by x-ray before we feed our patient. Always checking residual before we're refeeding our patient. Those type of things. And you guys know this, so bring it back to the forefront of your mind, because you're gonna be using some of these techniques when you're taking care of your patient. Abdominal distension is always can always be a problem as a result of some of these feedings. It's not so much the tube, but as it is the feeding itself, the solution that we're putting in. They also lead to nausea and vomiting, diarrhea, and then you can always have fluid and electrolyte imbalances anytime you're feeding your patient. Keep in mind that your potassium and your sodium are going to be your primary electrolyte imbalances when you have a patient on a tube feeding. The other way that we can feed our patient is parenteral, either partial parenteral nutrition or total parenteral. This is when we are giving our patient nutrients through the IV route. And we'll talk about TPN and PPN when we get into IV therapy in a couple of weeks. Okay, on the other end of the spectrum is obesity. Obesity really refers to an excess amount of body fat when you compare it to lean body mass. So we consider a patient obese when they're 20% over the upper limit of their normal range for the ideal body weight. A patient is considered morbidly obese when they're 100% over that ideal body weight. So really, obesity is determined by their weight when it's compared to the height, the body mass index, and the waist circumference. Okay. Causes of obesity is, of course, diet, physical inactivity. There are also drug therapies that can predispose a patient to weight gain. A person who's been on steroids for a while will gain weight and may need to have some type of adjustment to that. But it's probably that they need the steroids long term. People who are have long term steroid use for respiratory issues, they've got to have those steroids. So it's we add the obesity on top of the respiratory issues, and we do have problems to contend with. Patients who take estrogens, NSAIDs, blood antihypertensives, antidepressants, and oral diabetic meds. All of these things can predispose your patient to obesity and weight gain. So when we have a patient who is obese, what do we see? Of course, we're going to see excessive fat on our patient. Our patient may complain with shortness of breath with any activity They're very slow in their movement. They tend to kind of shuffle when they walk, so you do notice changes in their gait, and they may even limp. And then, of course, they're always prone to complications. Some of the disease processes that people get simply because they have that excess weight. Some of these complications have to do with cardiovascular and respiratory systems, the musculoskeletal system, and immune system. So patients who are obese have problems with diabetes. Okay, sometimes just weight loss will take care of the elevated glucose levels that they have. They have problems with hypertension, problems with hyperlipidemia, coronary artery disease, peripheral artery disease. Patients that are obese have an increased risk of stroke. They have sleep apnea. They have osteoarthritis or increased risk for developing osteoarthritis. Wound healing is decreased or slowed. They are more prone to develop gallstones, gout, and they also have back pain, and they can have depression. So lots of complications come with obesity. What we have to think about is teaching these patients. Okay, dietary teaching, exercise teaching, and then we really need to start early educating our adolescents, especially if they have a high risk of obesity in their future. If both parents are overweight, there's a very big chance that the children will be overweight as well. So we have to start our education early. So our teaching plan really has to be based on instructing our patients on the importance of weight loss, how to manage their weight, and then also the importance of exercise. Treatment for obesity may be a several step approach, but we always start out with non-medical approaches. Put the patient on a diet, and a lot of these patients that you talk to have been dieting off and on their entire lives. They've faced this their entire life. They've tried all sorts of diet programs, and your book alludes to many of them. Not all of them are the safest in the world for your patients. Fasting and fad diets, those type of things. What weight is lost is quickly gained back once the diet is ended. Nutrition therapy. This is where you actually have a consultation with a dietitian and who consults with the patient and the physician and the nurse, the healthcare team, to set up recommendations for this patient, looking at the patient individually and saying, based on their lifestyle, based on their current status, this is what's going to be the best plan for that patient. What should be their calorie intake? What should be their activity level? Those type of things. So they actually set a weight loss plan, and it's based on reasonable expectations for the patient. When we're looking at exercise, we all know that you have to get off of the couch and get out and move. So, again, when you're setting up an exercise program for your patient, just realize that somebody who weighs 400 pounds is not going to be, running out to get to the gym quickly, okay? We need to start slow and advance. Again, we need to have reasonable expectations and reasonable goals set for our patients. It may just be something as simple as having your patient walk 30 minutes 3 times a day. They don't have to run the marathon. They can just walk 3 times a day, and then gradually, 3 times a week. Walk 3 times a week for 30 minutes. That gets them out. That gets them moving, and then gradually increase their exercise plan. Now, there is drug therapy out there as well. Some of your anorectic medications. These are the things that actually decrease the appetite. The only one out there now that your book really talks about is orlistat. And then the one that you can buy over the counter, that's another appetite suppressant. And it works on the fat absorption. These two work on the fat absorption as well. But the one you can buy over the counter is a lower dose of orlistat, and it's Ally. So there's also some of your appetite suppressants that are loaded with caffeine and things like that, that also help with weight loss. But again, once you stop taking those medications, then the weight comes back pretty quickly. Behavioral management is one of the approaches that may be used. Having the patient self-monitor what they eat and drink. Having them self-monitor what they eat and drink by keeping a food diary certainly works wonders. Patients don't have an idea of what their intake is until they start to actually write down everything that goes in their mouth. It's kind of an eye-opener for them. Positive reinforcement, good counseling with these patients helps to alter some of these behaviors that lead to obesity. There are some alternative therapies out there, things such as acupuncture and hypnosis, that patients use to aid in their weight loss. And then, of course, we have surgical management, which is really doing some fantastic things out there. And your book talks about two different kinds. One of those is the gastric restriction. This is things like the lap band, where the physician or the surgeon actually laparoscopically goes in and puts in a band around the upper part of the stomach, which basically just makes a pouch that is the new stomach. So the rest of it, they're filling up the pouch instead of filling up the entire stomach. These bands usually have a port that is implanted in the abdomen, in the abdominal wall, that you can access to fill up the band with saline or something to close off the opening even more. So that's the way that they access. Patients do not have a lot of complications with the gastric restriction, because the absorption process is really not affected. It's really just the amount of food that can be tolerated. One of the problems you do have with the gastric banding is that when this fills up, your patient can have vomiting because it can't go anywhere else. So the amount that they eat is decreased. The more invasive type surgical procedure has to do and affects the absorption of the food that is eaten. So these are the malabsorption affecting surgeries, things such as gastric bypass. The most common one out there is the Roux-en-Y gastric bypass surgery. This is where the stomach, the duodenum, and part of the jejunum are bypassed so that fewer calories are actually absorbed. So when the patient eats, they've closed off the stomach here, and then the patient eats, the food comes down and bypasses the stomach, the duodenum, and part of the jejunum. So it's not, it affects that absorption there. Okay? So preoperative care for these folks that are having these bariatric procedures is sometimes your physicians will want them to actually lose weight, lose some weight before they have the surgery, because remember, these people are not in the best of health. Like we talked about when we talked about perioperative, folks who are obese have a higher risk of complications. So sometimes in order to have the weight loss surgery, they need to lose a little weight to even have the surgery. So that may be required of them. Patients usually will have some type of psychological assessment to check out their coping skills. What is their motivation for weight loss? Do they have substance abuse problems? Looking at their, how are they going to do post-op? Remember, somebody who's been overweight their entire life has a certain body image, has a certain, support system, certain, egocentric things about themselves that suddenly you're completely upsetting that whole system there. So, looking at how are they going to cope with this. Their life and their lifestyle is going to completely change, especially if they're having the bypass procedure. The thing about these surgeries is that with the gastric restriction, they lose their weight, but they tend to can gain the weight back. It takes a while, but they can gain the weight back. With the bypass procedure, your patient will lose a lot of weight, but they usually will keep the majority of their weight off. Okay. However, the bypass surgery carries more. It's more invasive, and it carries more complications with it than the restriction does. So we've got to make sure that our patient is going to cope with this huge change in lifestyle, and that they're going to have an adequate support system to help them through this new life that they're going to have. Preoperative education is pretty much the same as it is with anybody else. We've just got to make sure that they understand, again, post-operatively, what they can expect. Okay, and this is going to be one of the nurses' main things here, just like we talked about, is education with our patients. Now, once the patient has the surgery and it's post-op, it's done outpatient usually. The gastric banding can be done, and then the patient will usually go home in that afternoon. It is true outpatient. When we're talking about gastric bypass, the patient may stay over and spend the night. But post-op care, remember, these folks are at a bigger risk for complications, so we've got to make sure that we're monitoring for some of these complications. But our post-op care pretty much goes along the same route as any other surgical patient. Our priority post-op is airway management. These folks are at a bigger risk for airway compromise because they have these short, thick necks, and they may even need ventilatory support in the immediate post-op time until they get good and awake and can manage their airway. Okay, we need to make sure that our equipment is the right equipment for a bariatric patient, that we have the large beds and the large, the right scales, the right equipment to take care of these overweight folks. Patients are going to need an abdominal binder post-op. Remember, these folks are at a bigger risk for dehiscence and evisceration. So we're going to put an abdominal binder on them for a few days. They need to be maintained in the semi-Fowler's position, especially at night, so that they can maintain good open airway and good air exchange. Remember, these folks tend to have sleep apnea. So when they start going to sleep and have sleep apnea in the post-op phase, they have a bigger risk for pneumonia and atelectasis. So you may even be asked to set up BiPAP or CPAP for these folks at night. These folks are going to be on O2 for a brief period post-op, so we're going to monitor their SaO2. We need to make sure that we have some type of DVT prevention in place, either SCDs, TEDs, or heparin. Sometimes a combo of all of those, okay, may be needed for your patient. Your patient is post-op and overweight and immobile, so your patient needs good skin assessment. They're at risk for breakdown, remember. They also need some absorbent padding, especially under skin folds, places that may be, especially if your patient is incontinent or something like that. Some of them will have a catheter. Some of them won't. Okay, so if your patient is incontinent, we need to make sure we're keeping them good, clean, dry, because they get into skin problems very quickly. If they do have a urinary catheter, that is taken out as quick as possible within the first 24 hours. That way, we don't predispose them to urinary tract infection. Our post-op people have to get out of bed. Remember, we talked about get them out of bed and ambulate them as soon as possible, but they're going to get out of bed, especially up into a chair on the first day of surgery. Okay, they got to get moving. We are going to do the turn, cough, and deep breathe on these folks. Got to make sure though that they know how to splint abdominal incisions, so we don't have that adding to our risk for dehiscence. Ambulating them as soon as possible. We may be asked to monitor abdominal girth. That is where we are actually measuring the circumference of the abdomen. What we're doing is making sure that our patient doesn't have any kind of leaking at the anastomosis site where they've sewn together part of the bowel to the stomach. Sometimes they can leak from that site. You don't have that problem with the banding, but with the bypass you do have that risk. When patients they're held NPO for a few hours once they're awake and alert, and we can start to try to get them off NPO status. We start with very small feedings, very small servings of clear liquids. Usually an ounce or two. We don't want them to get dehydrated. They've got an IV, but we don't keep the IV too long. Remember, these folks are going home. So we start them on clear liquids, and we gradually increase the amount, but it's really increased in like 1 ounce increments. So very small feedings. After 24 to 48 hours, if they're tolerating clear liquids well, then they can add pureed food to their diet, but your patient is going to remain on liquid or pureed food for 6 to 8 weeks, for at least 6 weeks, okay? And then once that they're tolerating that okay, then they're going to be they can advance to a regular diet as tolerated, but their food needs to have some nutritional value, okay? It needs to be, the vegetables, fruits, looking at my plate kind of things, not the chips and ice cream and things like that. It needs to be good nutritional value foods. Once our patient starts to eat, especially after they've had the bypass surgery, the patient can have dumping syndrome. And we talked about dumping syndrome when we were talking about some of the other gastric surgeries that we talked. It's the same thing. It's still dumping syndrome, same thing. But again, remember, it's because the food has entered the intestine instead of the stomach in this case, or it's quickly gone through the that part of the stomach, okay? So your patient has the same symptoms: tachycardia, nausea, diarrhea, abdominal cramping, they're sweaty, things like that. So we have to adjust our intake to try to prevent the dumping syndrome in these folks. But remember, gastric surgeries, when we start doing that and rerouting and do, those type of things, your patient has an increased risk for dumping syndrome. And then, of course, we're always concerned with discharge teaching for our patients. They need to understand, just like any other postoperative patient, what is their diet, what is their wound care at home, their activity level, follow-up care with the physician. They need to know what to report, when to report, those type of things that we've already talked about. It's the same for these patients as well. Again, we do need to make sure that they understand about their activity, getting them up, getting them moving, and that needs to continue once they get home to prevent some of the DVT complications. Okay, I think that is all we need to talk about with chapter 63, and please let me know if you have any questions. Thank you.